Good morning. This is the San Diego Spine Foundation weekly didactic lectureship, and so excited to have Dr. Sheeraz Qureshi with us today from the Hospital for Special Surgery in New York. And Dr. Qureshi has made a huge mark in our field as it relates to minimally invasive spine surgery, and I can't think of anyone better to speak with us this morning about that very topic. And this morning, Dr. Qureshi is going to speak to us about robotic minimally invasive TLIF. And Sheeraz, would you mind sharing with me sort of your take-home points?
Absolutely. And Greg, thank you so much for that kind introduction. It's such an honor to be part of this lectureship, which I know you guys have had amazing people giving lectures. And it's I think for both of us, who love being part of education, doing these things are so fun and so critical. But the take-home messages by the time we finish, hopefully, are going to be that you always want to be cognizant of indications more than technology. So technology is cool and we love talking about it. And the talk obviously is going to highlight the use of robotics and doing a particular procedure. But always think about indications first and technology later. That's point one. Point two is whenever you're taking care of a person, remember that it's a shared decision-making process. You want to make sure that you have a conversation about exactly what you're trying to accomplish, and you want to make sure that the patient is comfortable with that, and listen to your patient so that you know what you are trying to accomplish, which leads into the third point, which is that your preoperative goals are really what should drive your intraoperative decisions. And that's what hopefully will get you good outcomes on the other end. So it's really a continuum that starts with indications, talk to your patients, and stick to your goals.
Love it. Well, we're still looking forward to what you have to share this morning. And thanks again for being here so bright and early.
So I'm going to talk about robotic minimally invasive TLIF. It is, going to focus on the technical aspects of doing this procedure and kind of workflow through my operating room. Quante Singleton, who's the fellow on my service right now, is on the call as well, and so he can also sort of vouch for sort of how things move and how we think. But at the end of the day, I do want to make sure that what we really want to get across here is that while this is a talk focused on technology and surgery, it's really the indications that are the most important. And the one thing that I feel is critical to emphasize, and I'll put it up front and then we'll hear it again in the end, is that we don't want to think about technology as a way to expand our indications. Unfortunately, all too often when people think about robotic surgery, they think about marketing, and that to me just never sits well. It really needs to be about, the best way in your hands to accomplish the goals, and there should be a shared decision-making process. Really important to make sure that that patients understand. One of the things that we do that I appreciate is that we provide when a patient checks in, like all of our conflicts with industry, so that patients know right up front, sort of that there is something to talk about there if they choose to. But let me go ahead and get into the meat of this talk, and I think feel free to interrupt at any point if you have any particular questions, and I'll try to get through hopefully this whole talk in the right amount of time. So when it comes to technology, I would say, it's constantly changing. So when we think about state of the art, it's really about the highest level of development of a technique or a particular device. But I think the most important thing when we think about state of the art is the time point that we're talking about. So because we're in a period of time that we're getting to live in where there's constant improvement in technology, it is really important to understand that what we're talking about today is not going to be state of the art 2 years from now, 3 years from now. So it's always, especially as you're going through fellowship training, you think like, okay, once I'm done with fellowship, I'm done. And I think it's really important to realize that with what we do, really take on this like learn, unlearn, and learn again. That's what makes our careers and what we get to do so special. with regards to enabling technology or for visualization in the operating room, you can see this huge explosion in the last decade. And I stopped the timeline at 2020, which I need to update now as we're, getting into 2025. But you could see that, there was some stagnation, sort of a century ago. But in the last decade, the enabling technology and the power of delivering that technology into an operating room, with regards to intraoperative visualization is literally changing every few months. When I think about my own career, sort of in minimally invasive surgery, there's been this sort of continuum of change with regards to what technology we're using. And I would say that that has come with an improvement in outcomes. And there's always sort of this ethical thing that sits inside your head. Well, should I not have done what I did, 10 years ago and what versus what I could do now? But I think, I've come to accept that, it's really like I think spine surgery is more like golf than it is football. You're always trying to better yourself with regards to what you're trying to deliver on as opposed to trying to compete with someone else. So what we're looking at on this slide, though, sort of the workhorse of minimally invasive procedures, are these tubular retractors, bayoneted instruments. I would say, like spine surgeons who do open surgery probably think about like a cob is how a minimally invasive spine surgeon thinks about a tubular retractor. That's like really kind of the workhorse of what we're doing. But visualization through that tubular retractor is so critical. I can't tell you every day when we see patients in the office, one of the questions that they always have around minimally invasive surgery is, well, how do you see anything? How is it that you can see through that little hole? And there are obviously multiple ways to do that. We could see a microscope here, which I think provides a lot of value. And there are other visualization tools like exoscopes or cameras that get attached to tubular retractors, which can provide value. I would say traditionally, fluoroscopy was a huge part of visualization, giving you a two-dimensional view in multiple planes. And then we can see that, there's navigation and then ultimately robotic navigation. And all of these things are steps of improvement upon previous, but you never want to lose the ability to make sure that well, here's how I'm going to use fluoroscopy, here's how I'm going to use navigation, and here's the additive value of a robotic arm as we think about delivering surgery. So for myself, the main one of the main impetuses for thinking about the adoption of technology for visualization in the operating room was about how to maintain visualization, but also reduce radiation exposure. And this was a paper that we published a few years ago, which was really based on data from very early in my adoption of minimally invasive procedures. So the data here was, based on things we were doing in 2011, 2012, probably 5 years into my practice. And it was really eye-opening to me how much fluoroscopy we were using to perform a minimally invasive TLIF surgery, which many people were, at that time were like, this is the workhorse surgery of a minimally invasive spine surgeon. And, we found that even at mastery, there was over 2 minutes of fluoro being used in a minimally invasive TLIF surgery. Um, the other issue is that you necessarily weren't getting the best outcomes. So this was a patient of mine who we looked at in terms of like I couldn't figure out. I thought I had done a good operation on this patient, an L5S1 TLIF surgery, and he had improvement in his leg pain, but didn't have any had actually worsening of his back pain, and I couldn't figure out what was going on. The X-rays quote looked good. And then the CT scan showed that we had, ruined his L4-5 facet joints. And that was a challenge in doing fluoroscopically based pedicle screws. And that's not to say that, that you cannot do better than this. I mean, this was early in our learning process and led to us going into a cadaver lab with some of my residents and fellows at the time who were our co-authors, and we sort of said, here's the sort of the ideal way to place a percutaneous pedicle screw so that we can reduce the incidence of proximal facet joint violation. However, I think you learn from your own mistakes, and this is where, technology can provide improvement. So when we first adopted navigation, we really wanted to see, well, does it help with radiation exposure? And does it increase the amount of time that it takes to perform a surgery? Because that was often a quote complaint of some of my colleagues who said, well, I don't use navigation just because it adds too much time. And what we found was that there was a significant reduction in fluoroscopy time. More importantly, there was a significant reduction in radiation dose during the surgery. And the most important part of the radiation dose was that the surgical team could really walk away, so the actual exposure is even less. And the operative time, while the fluoroscopically based procedures took less time, as you could see here, 92 minutes versus 108 minutes. As we became more and more facile, we continued to reduce the operative time for these procedures, which was really great. And then what about that facet joint violation? So there were, I sort of said, hey, here's the two big reasons. Like, I don't want to do bad surgery that's causing new problems, and I don't want to be exposed to more radiation. And we found that there was clearly a reduction in the number of times that you had facet joint violation of the superior facet. You could see, by significant, going from 0.5% or going down to 0.5% versus almost 10%, which was really important. So where does robotics fit into this? So, robotics often, I think, is a buzzword like AI or machine learning. But it's really important to know that robotics and spine surgery has been around for a long, long time. And I had I guess the benefit of jumping on early, but I did not adopt the first iteration of robotics. I chose navigation alone without robotics when I had the opportunity, because the early versions of robotics relied heavily on fluoroscopy still. And I thought that they were cumbersome, and they also didn't improve accuracy. There were still too many potential for mistakes. But one of the reasons that I bring that up is because if you don't sort of at least trial technology, um, you don't have the opportunity to help the companies and the people that are thinking about this and developing on what's important and how to make it better. So I would say that the current generation of robotics, which will be replaced by a next generation of robotics at some point, I'm sure soon. It's really important when you guys get out into your careers to, ethically have the ability to speak to our industry partners, because they're obviously trying to sell a product, but they don't want to sell products that aren't helping patients. And so it's really our job to help guide them in this. So the current robotic platforms that are approved by the FDA all fall under something that we call shared control. So, you may hear like, oh, look at this screw that the robot placed. Look how terrible it is. And I always say, well, it's not that the robot placed the screw. It's the surgeon that places the screw in spine surgery. And I think it's going to stay that way for a long time. So surgeons are always the primary in control, but there are these advantages. The robot doesn't get tired. It's going to hold position for us to place a screw without ever moving. And there is an increased precision in executing, which I think is important. So my perspective on current robotics and what are the advantages, I think we can reduce radiation exposure, as I hope to show you here. I think increasing pedicle screw accuracy is important. And I guess I would probably replace this with precision. I think you can more appropriately reproduce sort of the exact place of where you want your screw to be using robotic navigation as opposed to navigation alone or fluoroscopic visualization. And you also have the ability to optimize the size of the screw that you're using, which I think in minimally invasive surgery is particularly important, because especially when we're doing TLIFs, we try to put the biggest cage possible, but we don't get as big a cage as we do with lateral surgery or anterior surgery. And so having some rigid stability around the construct is important. And then you can see below here. But I think small learning curve is important as well. I think technology that requires a major learning curve that's an area of improvement. And I think the good thing with robotics as at navigation as is currently available, the learning curve is small. Where I think the learning can happen is really around workflow for the entire surgical team. So this is a paper that we published a few years ago, which sort of went through the step-by-step for how we do a robotically guided minimally invasive TLIF. So several of the pictures and videos that you might see are attached to this paper. But this is a view inside sort of the start of a robotic TLIF case. I am conflicted with Globus, so you're going to see a lot of Globus stuff here, but you could do this with anything. But this is sort of the patient setup, and I like to do intraoperative capture of the three-dimensional image. So this is that happening. I often will, kind of talk to our fellows about sort of this is to me in my head, sort of this part, and then the next part that you'll see, which is the planning process, the equivalent of an exposure that you might be doing if you're doing an open surgery. So then once that image is captured, it gets transferred to the robot as you're looking at here, and we go through the planning process. And what planning involves is not just the placement of the screws, but we get to rethink about the case. We've thought about the case when we first seen the patient. We've thought about the case the night before surgery, and now we get to rethink about the case before we are going to ultimately execute as the patient's under anesthesia. But here we're planning the screw trajectories, we're planning the screw sizes, we're planning the trajectory of the tubular retractor. And I think all of these things are important and give an opportunity to, for knowledge transfer and just a discussion around why we're doing what we're doing, and perhaps, kind of making any little adjustments that we need to make. I like to do my own planning. I know there are some surgeons who are okay with the, company reps planning or things. I would always say, do your own planning because only like exactly, kind of how you want those screws to be and things of that nature. In terms of educating and handing off cases to our fellows, this is one of our former fellows, and you can see here that we've planned the case, and Mike here is putting in a screw, and I can sort of sit back and we can talk, and I can heckle him and do whatever that we want to do, but at the same time I can see exactly where that screw is going. And this is the important thing. The robotic arm is great, but robotics without navigation, I would say, would be much less valuable. So the marriage between the robotic arm, which allows for maintaining the trajectory better, plus having the navigation is really critical. And that really was sort of the big improvement from first generation robotics to the generation of robotics that we're in now. In terms of the actual putting in the screw, I think probably similar to Greg, you always want to proceduralize as much of the things that we do as possible and put it into steps. And so the steps as we think about putting in a percutaneous pedicle screw through a robotic arm, you get your image, you do your plan, and now we've stepped on the pedal, which has come into place. So the first thing we've done there is make a skin incision. I now take a high-speed burr, and I'm making the opening hole here and just kind of feeling that out, making sure that what I am feeling with the tip of my burr matches what I'm seeing on the screen. So I don't want to feel soft when I should feel hard. I don't want to feel like that the navigation is showing me that I'm in the bone when I'm actually, think that I'm sitting on the edge. So you have to go through the thought process here. Don't just sort of shut your brain off and just say, okay, well, this must be right. The next step is using a high-speed drill after you've burred the starting hole. I tap, you don't have to tap, and then ultimately, we'll place the screw. So you can see that this can happen quickly, efficiently, and as we need to make any adjustments, you can see we're zooming in on the screen here so we could see a little bit better. But I think the most important thing here is make sure that what you're feeling goes along with what you're seeing. Don't turn your brain off and just accept because you're in primary control here. So that's really critical. In terms of the tubular retractor placement, so I think this is a really nice thing. We place the tubular retractor, we use the robotic arm to hold the retractor in place, and then we take this thing that I call a chicken foot, and we mark out everything that we can see within the retractor. So We know, okay, what's the medial most point of the retractor, and what area of bone is that getting me to? What's the lateral most area? What's the caudal and cranial borders? And now we've created our playing field. And if we need to make any adjustments, we can make the adjustments based on sort of as we've made our topographical map and we've said, okay, I'm right on the facet, or I'm a little too lateral, I'm a little too medial, I'm a little too low, I'm a little too high. So the tubular retractor can be exactly where you want it to be able to allow you to get the cage in the way that you want. I think disc prep is really nice thing to be able to use in a navigated way. So you can see here, sort of using navigation to get the areas with the curette and with the distractors to make sure that you're doing a good discectomy. One of the appropriate knocks on TLIF for a long time has been the fact that you do a channel discectomy and put in a little cage. And I think that, this allows us to change that and really do a good discectomy, a thorough end plate prep, and knowing what part of the disc we have prepped and we haven't prepped. Using these double bayoneted instruments and using a slotted tube, as we'll see in a second, allows you to really get all the way across and in all parts of the disc. And then ultimately implant insertion, which can be navigated if you want it to be. I often will use fluoro actually for this part because I use articulating cage, but this is just showing a non-articulating cage that we used in this case, where you can then match. Here's where I want my implant to be, and you can get it in the right position in terms of getting it in the right spot, anterior half of the disc space, from a lordosis perspective, and then very importantly, making sure that it's touching the areas that we have prepped with regards to fusion. So here's an example of a case. So this is a patient with an L4-5 spondylolisthesis. As you could see here, you could address this problem in many ways. In my hands, I like a minimally invasive TLIF for this procedure. And you can see here the sort of central canal is relatively okay, but significant bilateral foraminal stenosis. Here's this CAT scan showing the lysis, but very collapsed disc. Specifically in this patient, from my perspective, when the psoas is anterior like this, I even more so like to do a posterior approach here. And then I'll just kind of take it through the case here. So it's a mix of, kind of using fluoro, which I'll show you. But what the robotics allowed me to do here, you can see we could put in really nice long screws. So we've got almost essentially what we would consider bicortical fixation. I've got my tubular retractor docked exactly where I want. But now I have to function with some fluoro as well here. So it's really like, again, you can't forget all of the tools that we have because we want to restore disc height. We want to get lordosis back. So now we're putting in our expandable cage, and you can see here that we can start as we expand, we can get really good lordosis. We've sat the cage kind of anteriorly on the L5 vertebral body, and now we've opened up the disc space and really gotten good lordosis here from compared to where we started. And then this is ultimately where we ended up here with this patient. And I think, having the ability to do this through a minimally invasive TLIF approach, I think provides a lot of value because I think, especially given this patient's anatomy, a lateral surgery, at least in my hands, would be difficult. And at L4-5, if I can avoid having to go anterior and get away from the vascular concerns at L4-5 that can be in some patients, that's just my preference. So we've looked at this in our practice analysis of 1,000, our first 1,000 screws, and we found that that it's safe. That was the most important thing. In terms of screw size selection, like we talked about, I think if we did this study again today, we would find that we've actually even gotten to bigger and longer screws now, because we feel more and more comfortable putting in even bigger, even longer screws. In terms of that discussion around radiation exposure, we found that the use of robotic navigation versus traditional navigation further by a small amount reduces radiation, and I think that's continues to be important. And the learning curve is small. So I think those are sort of the three important things. In terms of clinical outcomes, we've looked at the differences in our patients who we've done robotically versus with just traditional navigation, and we haven't shown a difference, which is okay. I'm hopeful that ultimately we'll be able to show a difference in fusion rates, however, because I will say that I have anecdotally right now found that my fusion rates seem to be better for single level surgery with robotics. And I think it's because we're putting in bigger screws. In terms of where we go with this, and I know we're going to be up against time, so I'm going to stop quickly here and just run through these really quickly. But the key thing is going to be data and learning, and I think this was a paper that we published that I really like, and I hopefully all you guys will have a chance to look at it. But I would say that where we are now is sort of where we were with the industrial revolution, and where we want to get to is the computer revolution. So I think robotics, very similarly to when we went from artisans to machinery, we're going from surgeons to robotic assistants. It allows for a more accurate tool path. And similar to what we heard when computers were being thought about, we hear about robotics, that they're too expensive, and which I agree with, and they're not really great for private practices or ASCs, again, which I agree with. But ultimately, without the internet, computers would be useless. And my hope is that we get to a point where we have robots all sort of like being the data repository, and that's how we're all going to get better. So a network really of spinal robotics is sort of where I think the future is, and that's where pooling data is going to be so important. And ultimately, that is what's going to drive down cost. So I'm going to finish up with the take-home messages that we started with. Always make sure that make indications are key. The technology is great, but it's really about the indication. Shared decision making with the patients is critical, and you always want to stick to the goals that you came up with preoperatively. I think you want to always avoid kind of making things up on the fly. Figure out what you want to do preoperatively, talk about it with your patient, execute on it during surgery, and that's what gets you the best post-op outcome. So I really appreciate everybody's attention, and I will stop there and happy to answer any questions.
Thanks, Shiraz. Appreciate you, man.
Yeah, Henny, thanks, man. Great to see you.
Good to see you too. I have kind of one really specific question. Are you able to use that same 3D C arm to do your fluoro shots as well? I mean, do you just get a spin and you come in with a regular fluoro, or is that pretty facile and you get your fluoro shots with that as well?
Yeah. So, yes, you can use that 3D arm for your fluoro shots. I tend to, because we have one 3D arm, and oftentimes there are multiple surgeons who are doing robotic cases. What we do is we use 3D arm for the spin, and then actually have it taken out of the room, and then have a regular C arm that gets draped for the part of the surgery where we're placing the cage. Because I use an articulating cage, you can't navigate kind of that movement and expansion right now. But for those surgeons who use a cage that you can, sort of plan and navigate, the 3D C-arm comes out, and then they actually don't end up using a C-arm unless they really need it. But for me, yeah, it's kind of do the spin, it comes out, so it can go to a different room.
Thanks, Dr. Qureshi. You talked about the evolution of technology, kind of going back and through nav and robotics. I was curious, what are your thoughts on the next gen of things like augmented reality, on point, augmetics, things like that are now being used for MIS TLIF?
Yeah, I think they're all great. Then that's where, like, I think, trying these things, figuring out what works best with your workflow and in your hands is critical. I used Augmetics briefly, kind of to as a trial, and there were certain things for me that I just liked about robotic navigation as opposed to Augmetics, but I think that these are all additive technologies. I think some of the advantages of augmented reality hopefully are going to be that you're going to have the ability for having a lot more things kind of that you can manipulate, meaning like, hey, I want to look at that pre-op x-ray again, or I want to look at that MRI, and sort of either by blinking or moving your fingers or things like that, everybody who's wearing the glasses will be able to see those things. So that's where I'm hoping we get to. And then I think from a next gen robotics perspective, I think one of the things that I miss about fluoroscopically based minimally invasive surgery, at least when it comes to screw placement, is the ability to do it simultaneously, which I think is, much more efficient when you're doing it under fluoroscopy. And so probably at some point having sort of a dual armed robot where you can work simultaneously with your with the person on the other side of the table for placing screws, I think will add value because it'll be more efficient.
Dr. Qureshi, hey, nice to see you again.
What's happening? It's good to see you.
I was wondering if you can kind of touch on kind of some of the things that you've instilled in your procedural steps to help kind of bring down the operative time, especially when applying and using the robot, as you kind of mentioned in your talk. Not to have you give away too many of your trade secrets, but kind of what are the things that you've done to expedite that a little bit more and make that more efficient?
Yeah, so I think you've been in the OR with me, so like for me, the concept of team is critical. And you want to be the leader of your team, but you don't want to be in the back of the cart. You want to be in the front leading. And so I think the most important thing is just being present. So as you know, I'm there start to finish with positioning and things like that. And then making sure that everybody, when they see you sort of helping with every part, like everybody else in the room helps also, and everybody sort of knows what what needs to be happening, so where the microscope needs to be, where the 3D C-arm needs to come in from, where the 3D C-arm needs to go out from, where Drew, who's my surgical tech, needs to be, and where, so I think that's probably the most important thing when it comes to being efficient is be present, so that it's all sort of hands on deck, because that is the one thing that I found is like when we talk about like robotics as a stress reducer in the operating room for the surgeon, I think there's no question the level of stress of putting in a robotic screw for the surgeon is less than the level of stress putting in a perk screw without robotics. But you do transfer the stress like to your team because they've got way more trays to open and like and sort of other that stuff moving around them. So when you see that, like it's one of the things we did this year was reduce the number of trays and things like that. So but I think when it comes to workflow and continuing to improve efficiency, I think just being present so that you can recognize it and push it forward is the most important thing.
Hey, Dr. Qureshi, real quick question. Jamie Bruffy here. I'm one of the spine surgeons in the group.
Hey, Jamie, how you doing?
You made good. You made an interesting comment. You named your tech by first name. So do you have consistent staffing in your OR when you do your cases? Is it always the same team?
Yeah, it's really important for me to have that, and it's like so there's two sides to it. I mean, obviously everybody's got to take vacations and or be out of town or sick days. So the benefits of having the same team are that when everybody's there, it's it's beautiful. The downsides of having the same team are that when somebody's not there, who's going to be coming in. But we're very lucky. I have the same team in terms of my nurse, my anesthesiologist, my scrub tech, my neuromonitoring person. Everybody's the same. And that kind of comes with that, like that team concept, like Yusuf and I were just talking about. Like, you sort of have to create that culture in your room. But then I also have like a backup team that tends to be the same group of people for the most part. So we're very lucky, but I think it's really important when we're thinking about efficiency is having the right team.
Does your institution support that? In other words, when you're in the OR, they are assigning that team to you for the day, I'm assuming, and they're done when you're done. Is that how it works?
Yeah, so we're moving towards that. So my team stays with me until I finish, but if I finish at 4 and they're supposed to be there till 7, they're still there till 7. And what we found was that does create a lot of dissatisfaction because my team is like, well, we're super efficient and we got X number of cases done by 4 o'clock. And now instead of being rewarded, we're actually being punished because we're going to get another case put into this room. Whereas another team who was much less efficient only did 1 or 2 cases. And instead of having to do their third case is coming in our room, so to speak. So it's a balance that we're trying to figure out. So that's what we're trying. So it's a balance that we're trying to figure out, and what we're trying to shift to is almost like an ASC like concept where when you're done, everybody's done. We're not perfect yet, but we're working on it. And yes, our institution, I think one of the things that we're lucky here is that the institution and the leadership on an administrative side recognizes it and wants to make it better for everybody. So yeah, so we're trying to get there.
Super helpful. Thanks.
Hey, Dr. Qureshi, Gotham here. We met in Vail.
Yeah,
Good
good
to
see you. Yeah, we saw each other at Vail. That's why I'm
Yeah.
giving this talk.
That's right. That's right, baby. That's right. Hey, I just wanted to ask you, great talk. It definitely opens our eyes here because we don't use a ton of robotics just yet. But, at least in residency, I had heard some horror stories regarding the earlier iterations of the robot. And I guess my question is how do we stay out of trouble with robotics and what do we need to look out for so there's not, screws going into the canal? I know obviously you said, you have to be cognizant of everything going on, use your tactile feedback and whatnot. But are there, because I've heard multiple stories of screws going in the canal, and that's just, that's like definitely scary. It's something.
Oh, absolutely. So I think you have to, there, while the learning curve is small, it's not to say that there's no learning curve. And I think one of the best things, if you're starting to use robotics and you haven't had that, you haven't sort of gone through it during training, is like spend a couple of days at a place where you could just watch kind of the workflow and things that are happening, because there are little subtle things that can happen that sort of shift the registration in a certain way and things of that nature. And I think that's where problems occur, is where some sort of a shift has happened and you get like a little red dot somewhere, and instead of sort of saying, all right, I got to do this over again, I screwed up and I got to respin and I got to redo everything, that you just sort of say it'll probably be okay, and that's where you get in trouble. And then I think that so I think that that's really important, is I think that's where the errors happen, is because there's a registration shift. There's the fiducials that you see in the pelvis, and it just shifted a little bit because you were taking the drape off in a certain way, and it moved just a little bit before the registration transferred, and now the whole thing's off. And these are the learning curves that the learning curve that we went through, and sort of, and because I had done a lot of navigation, the learning curve was smaller. But I the advice I would give is like spend time at a place that does a lot of robotics so that you could kind of see it and kind of say, yeah, okay, I understand, and talk to people, so you don't make the errors. And when you get any inclination from the robotic screen that something might be off, take it seriously. Don't just say, because you've got two more cases to do and you don't want to start the whole spin over again. You just got to eat it at that point and say, okay, I got to do this over again.
Awesome, Sheeraz. Thank you. We want to respect your time too.
Thank you.
So grateful for you being here and sharing. And obviously, we always love listening to you on the circuit. So I'm sure we'll see more of you. But
Awesome.
have an awesome day. Thanks, everybody.
Yeah, thanks everybody.
Thanks,
Really
Josh.
appreciate everybody's time. See you guys.